Welcome everybody to this evening's lecture. Vet Education is proud to present a free webinar on dog bite wounds in cats. This webinar is being brought to you by an upcoming Vet Education online course for veterinarians called Trauma Management in the Dog and Cat. It's a course that starts in just a week and a half, starts on June the 10th, 2024. There's a picture of a cat with head trauma. There we'll be talking about head trauma in this course. As I mentioned before, it starts June 10th, 2024. It's a 4-week online course. It is approved for 20 race CPD points. If you don't need race, it is also eligible for 20 hours of structured or assessed CPD as well over the 4 weeks. We will be presenting the latest scientific literature on trauma management and all aspects of trauma, from thoracic trauma, cardiovascular trauma, head trauma, abdominal trauma, urinary tract trauma, wound management, pain management, and a whole bunch of other things as well in there. So there's a ton of stuff to learn and to find out about in the course. Because you lovely people have come along to the lecture tonight, we have got a special discount for you. If you scan this QR code, which is different from the one that you download your lecture notes on, you will be able to register at discount code Trauma24 is that discount code, and that will give you a 5% discount off the cost of the course. We're talking about dog bite wounds in cats. I'm your speaker this evening, Dr. Philip Judge from Vet Education. I've been an emergency clinician now for 26 years, and I've seen my fair share of dog bite wounds in cats. I've held a number of roles from senior lecturer at James Cook University in Queensland to the head vet at the Animal Emergency Centre in Melbourne. Currently, I run Vet Education with my wonderful wife, Charisma, who many of you will have had messages from via email over the years. But I also work in an emergency clinic in Cairns, Emergency Vets 24/7, an amazing crowd up there. We see tons of really interesting things up there because it's in the tropics, in the wet tropics, so there's lots of interesting cases to sink our teeth into. But tonight we're talking about sinking teeth into cats, if you're a dog, that is. And why are we talking about this topic this evening? Well, dogs can generate quite a lot of force when they bite a cat, up to 450 pounds per square inch. That's a fairly significant force that may be applied to whatever a dog actually bites. And that can translate, when the energy is dissipated, into body tissues, significant body tissue injury. Now, when dogs bite other dogs, yes, we're aware that there can be quite significant soft tissue, sometimes skeletal, sometimes deeper tissue damage in our patients. And when dogs bite cats, because cats' body mass is so much smaller than other dogs, or the majority of dogs, they can suffer significant injury at quite some distance from the bite site. And we'll spend a little bit of time tonight talking about that. The bite itself can cause quite significant soft tissue injury. Now, dogs' teeth are not all that sharp, and so oftentimes we don't even get that much of a wound. Sometimes you can get a wound for sure. There can be tearing into the skin or puncture of the skin. But oftentimes the predominant injury is actually soft tissue injury underneath the skin. If there is a bite wound, it's frequently quite small, except in various isolated cases where a dog picks up a mouthful of skin and tears it, in which case it can deglove part of a significant part sometimes of a cat. But there's oftentimes significant soft tissue injury to the subcutaneous tissues, the muscular tissues, the fatty tissue, and tissues even beneath that, the lungs, the myocardium, for example, intra-abdominal trauma. In fact, I will go back one slide here to this image here. This is obviously a patient who is having an exploratory laparotomy because they've been bitten by a dog. And we can see that while there are actually very few superficial injuries in the skin, that beneath the skin, there's actually numerous pressure-related tears in the peritoneum of this particular animal. In fact, this particular animal had an avulsed kidney as a result of their dog bite. So the bite injury can cause significant soft tissue injury, sometimes at quite some distance from the bite injury itself. In some cases, there can be skeletal injury. We can fracture bones in the distal limbs, but also have patients who have fractured ribs, fractured vertebrae, fractured skulls, depending on what part of that animal gets injured. As a result of soft tissue injury and sometimes skeletal injury, there can be quite significant systemic inflammation that results from that soft tissue injury. Whenever we injure body tissues, the natural response of our patient's body and immune system is to mount an inflammatory response to that tissue injury. Now, if we have a small amount of tissue injury, say it's on a toe or something like that, then that inflammation can be reasonably localized. But when we have significant body tissue injury, as we oftentimes get with cats that have been bitten by dogs, the inflammatory mediators that get both released and activated from areas of tissue damage are not necessarily confined to the area of tissue damage. They can enter systemic circulation and lead to systemic inflammatory response syndrome and sometimes the development of sepsis as well. And sepsis is really critical in the development of how well our patients do in hospital, because as patients develop worsening injury, if they develop sepsis, their mortality rate tends to increase. And we'll talk a little bit about that later on tonight, and certainly a lot during the online course that we're running in support of this webinar as well, because sepsis and organ dysfunction, the worse that is for our patient, the worse their prognosis is. So we're going to talk about some strategies tonight that can help us minimize the risk of systemic inflammation developing in our patients and minimize the risk of sepsis, as well as how we might manage the wounds in our patients as well. Now, the other reason why we're talking about dog bite wounds in cats is that the mortality rate for dog bites in cats in published literature is anywhere from 15 to 27%. Now, that compares in dogs with more published mortality rates of 7% or less. So cats perhaps 2 to 4 times more likely to die after a dog attack than dogs are from the same sort of injury. Some of it is size related, but a lot of it is due to the fact that cats end up suffering such significant systemic inflammation as a result of their bite wounds, and they hide a lot of that systemic inflammatory response as well. A dog will generally physiologically give you quite a lot of clues that things are not going all that well, whereas cats are a little bit more secretive. We'll talk about that later on tonight too. So aside from the local tissue injury that might occur in cats, we might get some skin puncture wounds and a little bit of bruising in the area surrounding that bite wound as well. That's going to cause a bit of local inflammation. We can also get skeletal muscle injury. This photograph I showed you earlier of intra-abdominal muscles that have been torn as a result of a dog bite, but it need not necessarily be in the abdominal cavity. It could be in the chest cavity, could be in muscles to do with our appendicular skeleton or the axial skeleton as well. We might also get, as we mentioned before, orthopedic injury of varying types. We may end up with closed fractures, or even in some cases open fractures. We might end up with degloving injuries or partial degloving injuries as well. We could end up with body wall injury that causes herniation of abdominal contents into the exterior environment. We may even have injuries that cause body wall injury to the thoracic cavity, causing an open or sometimes valvular pneumothorax in our patients, and they can present to us in varying degrees of respiratory distress that you and I need to know how to manage. This is a radiograph of a patient with a diaphragmatic hernia. And don't forget that the diaphragm is probably the weakest of all of the abdominal muscles. So if you have a dramatic increase in intra-abdominal pressure sufficient to cause injury in the abdominal wall, and whether the lateral abdominal wall or the ventral abdominal wall, don't forget that there is definitely potential for your patient to have ruptured their diaphragm as well. So thoracic imaging, in particular thoracic radiography, is a lovely tool to use for the diagnosis of diaphragmatic hernia. We can also end up with bruising to the pulmonary parenchyma. We can end up with patients with massive pulmonary contusions. Imagine a cat being picked up by a dog and shaken a little bit and put down again. That shaking can cause significant injury to the pulmonary parenchyma. So we can end up with a patient that has pulmonary contusions in a similar way to what we would expect for a cat or a dog that had been hit by a car, for example. But don't forget, we can also have myocardial injury. The last time that I saw a myocardial injury in a patient, this is granted, it was a dog that was run over by a car, was a matter of just a few weeks ago, and this dog had persistent tachycardia, heart rates of in excess of 180 to 190 beats per minute, unresponsive to analgesic therapy, correction of electrolyte abnormalities, fluid therapy, and so on. And this patient ended up going into cardiac arrest simply as a result of myocardial contusion as a result of their road traffic trauma. Now, cats can suffer a similar fate from a dog bite injury as well. And I have seen this happen, particularly in cats that are stressed when they, and by stressed, I mean physiologically stressed, during handling, during diagnostic imaging, and during anesthesia. And so it's very important for us to consider the fact that there may be, or consider the possibility that a patient may have myocardial contusions as a part of their overall soft tissue injury following dog bites. We might end up with organ rupture of the liver, the spleen, or we may end up with pulmonary rupture causing a traumatic pneumothorax with or without external puncturing of the chest wall, just an acute rise in intrathoracic pressure against a closed glottis can lead to lung rupture in the cat and can cause pneumothorax, can cause hemothorax as well. But don't forget that cats are just like dogs and that they can suffer from internal hemorrhage as a result of trauma. So we need to be able to evaluate and manage these patients appropriately. Now, obviously, with local tissue injury, particularly if there is a defect in the skin, there can be complications with inoculation of bacteria. Dogs' mouths are not all that clean, and dogs' teeth will oftentimes leave behind bacteria, but bacteria can also gain entry into wounds from the skin of the cat. They can also arrive there from hematogenous routes through translocation across the intestinal tract, urinary tract, the respiratory tract, if there is injury in any of those organ systems as well, and so we can get hematogenous spread as well. They can also gain entry into a wound from the environment that that cat is in, the hospital environment in particular. And by the hospital environment, I don't necessarily just mean the tables and the cages that these animals are placed on. I mean that bacteria from you and I can gain entry into our patients' soft tissue wounds and can cause significant and sometimes complicated infections in our patients. So one of the key tenets of managing wounds in our patients is that we don personal protective equipment, not necessarily to stop us from getting infected from the cat, although that is a consideration, especially if the owner may have been scratched or injured. They may have their blood on the patient, and we may not want to, well, we shouldn't come in contact with other people's blood if at all we can avoid it, to prevent transmission of diseases like hepatitis, for example, HIV. We don't know what our clients may have. They may not even know what they have, and we could get infected with that. But the reason we're going to don personal protective equipment on ourselves is to reduce the risk of us transferring bacteria from our skin into the patient's wounds, because that could be a significant problem for our patients. So local tissue injury is frequently associated with inoculation of infection. We'll talk about antibiotics in a little bit of time there as well. I mentioned before systemic effects in our patient as a result of tissue injury. And one of the big things is systemic inflammation. We know cats are small, and so when they get bitten, even by a small dog, there's oftentimes significant tissue injury, and that causes significant inflammation. The inflammatory mediators that get released as a result of the inflammatory cascade that occurs secondary to tissue injury have numerous effects on a wide range of body tissue functions. Among those are massive activation of the coagulation system, the fibrinolytic system. We get massive activation of release of vasoconstrictors, negative inotropes, vasodilators. We get damage to endothelial glycocalyx, which increases vascular permeability. There's also other cytokines as well that increase vascular permeability, so our capillaries become more leaky, and so fluid and cells and protein are more likely to leak out of our blood vessels into the interstitial spaces. This leads to a loss of intravascular volume, and so a lot of our patients in systemic inflammation end up being in a state of hypovolemic shock as a result of this as well. So those are just some of the systemic inflammation effects in our patients. We mentioned before that not only can our wounds become infected, but hematogenous spread of bacteria in our patient's system can lead to the development of sepsis. Now, sepsis is usually systemic inflammatory response syndrome that is complicated with infection. You don't necessarily need infection in order to start a systemic inflammatory response, but you do need infection to end up in sepsis. And most cases of severe systemic inflammatory response that progress to the point in which our patient has septic shock usually have complications with sepsis. Now, I see Jose's mentioned here, does periodontal disease in the aggressive dog represent an increased risk for soft tissue infection in the victim, and can that affect antibiotic choice? The short answer to both of your questions is yes. It can. If you have a dog with severe dental disease that bites an animal, then that wound is more likely to be inoculated with significant numbers of bacteria, sufficient enough that it could result in infection. Will the presence of severe dental disease in our patient affect our antibiotic choice? For sure. I think it might mean that we are more likely to choose antibiotics that perhaps have an enhanced anaerobic spectrum that are going to cover microbial agents that live in the oral cavity. So things, bacteria like Fusobacterium, for example, many of the bacteria that we see in patients' mouths. Once our patient gets sepsis, they're at high risk of developing organ dysfunction. And organ dysfunction doesn't necessarily just mean acute kidney injury. It can mean that your patient starts to vomit or has diarrhea. In the case of a cat, they might just stop eating because their intestinal motility is abnormal, that perhaps they have gastric stasis or gastrointestinal hypomotility. It could be that your patient has myocardial dysfunction as a result both of direct myocardial trauma, but also the impact of certain cytokines. In particular, nitric oxide, for example, is a potent negative inotropic cytokine, and so that will cause a decrease in the force of cardiac contractility, decreased cardiac output, and potentially the development of cardiogenic shock, which in cats can also cause pulmonary edema as well, because cats are quite sensitive to that in their lungs. So we can also have neurological dysfunction. We can have development of disseminated intravascular coagulopathy, or DIC, as well. So how are we going to approach this poor little cat? Clearly, this cat has not been bitten by a dog. This is a photograph of a perfectly healthy little cat. But how are we going to approach our cat that has been bitten by a dog? Well, it begins with initial patient stabilization. And we do this for every emergency patient that presents to us, particularly our post-traumatic or post-trauma emergency patients, where we systematically evaluate the respiratory tract, the cardiovascular system, the neurological system, and then other body systems to see if we can identify anything that's going wrong with our patient in those systems, and then try to remedy as much as we possibly can before or at the same time as moving on to subsequent body evaluation. We start off with the respiratory tract because without a functional respiratory tract, our patient will very quickly die. The next system we move on to is the cardiovascular system, for the same reason that if our patient is able to breathe, but they're in significant shock, for example, or perhaps they have significant bleeding, that those patients are at a much higher risk of going into cardiac arrest. The neurological system follows the cardiovascular system stabilization, or evaluation and stabilization, because without a functional brain, the heart and the lungs don't work as well as they normally should, and so that also increases the risk of our patient dying. So let's just have a brief talk about stabilizing our patient's respiratory tract. Any patient with respiratory compromise, we should be giving oxygen supplementation to. And in cats, we need to give oxygen in a manner which is not going to increase anxiety and stress in our patient. So for some cats, this might be putting them in an oxygen cage. For others, it might be putting an Elizabethan collar on their head and making a little oxygen hood for them. And yet others, it may be that we decide to put nasal oxygen catheters in them. Depends really on the cat. The one contraindication that there is to placing a nasal catheter in a cat is, well, it's really two. If the cat gets stressed or anxious as we're placing it, and the second is if our patient has craniocerebral trauma or head trauma, traumatic brain injury. I was getting ahead of myself with my sentences there. If your patient has traumatic brain injury, we generally don't put things up the nostril because that can stimulate our patient to sneeze. And when our patients sneeze, it increases intracranial pressure. And that's something we want to try to avoid. If our patient is having trouble breathing because of poor airway, we need to do the best we can in terms of clearing that airway. For some patients, it may just be that we use lap sponges or swabs. I usually prefer swabs in cats, and I will put swabs, clamp them with perhaps some small forceps, some artery forceps, and just use those dry swabs to scoop out of the mouth any blood and mucus and debris that there may be in the oral cavity. You can also clean around the external nares as well, any blood clots and mucus and saliva that's there as well, to try to reduce the resistance to airflow through the nasal cavity and the oral cavity into the larynx and subsequently into the trachea. But it might be necessary for, and particularly in patients that have significant soft tissue injury around the pharynx and the larynx, it may be necessary for us to place a transtracheal oxygen catheter, or even to consider emergency anesthesia and establishment of an airway with an endotracheal tube as well. Oh, I haven't quite finished about talking about respiratory complications. Thoracic wall or pleural space evaluation is the next thing that I'm looking at. And please type in the chat there if you are regularly using T-fast and lung ultrasound to check for your patients the presence of pleural space disease in your animals. I really like the technique because it is fairly low stress for your patients. In the days before lung ultrasound, we would do diagnostic thoracocentesis, but I feel that lung ultrasound is a nicer way to go about things, because if my patient does not have pleural space disease, then I don't need to stick it in the chest with a needle and get a negative finding. So utilizing lung ultrasound, I think, is really helpful for that. If we diagnose a pneumothorax or a hemothorax, for pneumothorax, I'll talk about first, we want to perform thoracocentesis to remove all of the air that is in the pleural space. It doesn't belong there, and your patients will breathe much better as a result. Always check both sides of the chest as well. Now, if your patient has a hemothorax, again, remove as much of the fluid as is necessary to improve respiratory function. If your patient is bleeding significantly into the thoracic cavity, there's a couple of things that you can do for your patient. One is to keep the blood that you are removing from your patient. You might be able to use that blood as an auto transfusion, run it through a blood filter to filter out the blood clots that are there and administer that to your patient intravenously if you need to, if the bleeding is significant. So definitely managing pleural space disease, and in some cases you might need to go on several hours down the track and place a chest drain in some of those patients as well. Thoracic wall injuries, if you've got a puncture through the thoracic skin and into the chest cavity, you're going to need to do a couple of things. What I really like to do is to use local anesthesia, usually just with lignocaine to begin with, because it stings less than bupivacaine, and just to use intercostal nerve blocks over the area of that bite wound. So you're injecting just caudal to the rib, usually 1 to 2 intercostal spaces cranial to the bite wound, and at the rib space, intercostal space of the bite wound, and then 1 intercostal space caudal to that, both dorsally and ventrally. So as far dorsally as you can get in the rib cage and as far ventrally as you can get close to the sternum. And that will anesthetize that part of the chest wall to begin with. And that makes wound care quite a lot easier. You can clip around that wound. You can fill that wound with swabs and hydrogel. You'll be able to clip that wound and actually put maybe something in the way of a vented sterile occlusive dressing. There are a few brands of these. If you just Googled a vented sterile occlusive dressing, the way these dressings work is that when the animal is breathing in, they close up, and as the animal is breathing out, any intrathoracic air gets vented out through one corner of the dressing. They're used in human beings reasonably well. I have used them in dogs. I haven't used them in cats. They seal reasonably well, but you do need to shave the skin before you are applying these. Otherwise, what tends to happen is you get leakage around that bandage. But these are things that you can use. It's essentially like using a Heimlich valve that actually vents the thoracic cavity of air as well. It's just that it's something you can slap on that chest wall, and the valvular action of those vented dressings can help reduce intrathoracic accumulation of air. Pulmonary contusions, we might be able to pick up with lung ultrasound as well, and we manage those with oxygen. We use antithrombolytic therapy such as tranexamic acid, if you've got it, or aminocaproic acid, or any of the other antithrombolytic drugs, depending on where you are from, plus or minus the need for ventilation therapy if needed. Cardiovascular instability in our traumatized cat. We need to control internal and external hemorrhage, treat hypovolemic shock using fluid therapy, and usually I'm just using lactated ringer solution in cats. The dose that I'm going to use to treat shock of lactated Ringer's solution or Ringer's acetate, again, depending on what fluid you have most available to you, is just 7 mils per kilo, giving in 10 minutes, and then reassessing my patient to see if there has been a response. And I might repeat that dose of shock rates of fluid, 7 mils per kilo in 10 minutes in my kitty cat, maybe 2 or 3 times in half an hour. By which time, if my patient has not responded to treatment for shock, I'm going to reduce my fluid rates to maintenance and go looking in my patient to see if there's something I've missed. Maybe my patient's developed a pneumothorax. Maybe it's developed a hemoabdomen. Maybe it has head trauma. Maybe it has myocardial contusions and has an abnormal cardiac rhythm as a result of that. So these things are all things we need to monitor. Patients and cats really need a PCV of around about 25 to 30%. We sort of say 27 to 30% most of the time there, in order to not suffer from the hemodynamic effects of decreased oxygen delivery secondary to anemia, if that anemia develops quickly. We all know of cats with chronic kidney disease that might have a PCV of 12 or 13%, and they seem to be cardiovascularly quite stable. But if our patient has an acute blood loss such that their PCV drops down to a PCV of around 20 to 24%, we frequently see tachycardia, maybe the development of tachyarrhythmias. We see tachypnea, so rapid respiration, and weak and thready pulses as a result of that acute blood loss. And so transfusing our cat to a PCV of around about 27% is ideal for most cats, especially cats recovering from significant bite injury as well. Abdominal cavity hemorrhage, we would diagnose generally with a fast ultrasound, and we control that using antithrombolytic therapy such as tranexamic acid, and maybe the application of external compression bandages as well in the acute period. Some animals might need surgery. The majority don't need surgery in order to rectify problems with regards to intra-abdominal hemorrhage. Most hemorrhage in dog bite wounds in cats does not seem to occur as a result of laceration of a single vessel. It's usually caused by contusions to the liver or the spleen or both. And so increasing intra-abdominal pressure usually is sufficient in the majority of cases. I've written in your notes that we don't want to exceed an intra-abdominal pressure of greater than 14 centimeters of water pressure, and that's certainly the case. In our trauma course, we actually have a section devoted to how to apply an external abdominal compression bandage to our patients and how to monitor intra-abdominal pressure as well using a urinary catheter. So it's pretty cool. As far as neurological stabilization is concerned, it really begins with an evaluation of the respiratory tract and also the cardiovascular system as well. If your patient has bite wounds or obvious head trauma, then we need to manage that separately. And as I've already mentioned, that begins with control of the airway, ensuring our patient's got normal ventilation, and treating a patient for shock. There's a couple of things with regards to the neurological system. A patient that is not ventilating normally will have worse neurological outcome, particularly if they're hypoventilating, so not breathing enough. If their carbon dioxide concentration increases in circulation, the brain will swell due to increased vasodilatation in the brain. And that leads to compression of capillary beds in the brain tissue itself and decreased neuroperfusion, and that worsens neurological outcome. The second thing that we need to do for our patient is to ensure that our patient has normal systolic arterial blood pressure. That is systolic arterial blood pressure of somewhere between 100 and 120 or 130 millimeters of mercury pressure. Hypotension, so Systolic arterial blood pressure of less than 90 is associated with worse neurological outcome as well. So ensuring that your patient has normal blood pressure, normal CO2 concentrations, and optimal oxygen saturation of their blood as well is vital. The other thing I will mention is that sustained hyperglycemia in cats is associated with worse neurological outcome too. Now, it's normal to expect that a traumatized cat with head trauma is going to be hyperglycemic. We see that quite commonly in cats immediately post-trauma. But cats that have sustained hyperglycemia, so you test the blood glucose maybe a couple of hours after the patient comes into your clinic, if the glucose concentration is still really high, and I'm talking in millimoles per liter, sort of around 15 to 20 millimoles per liter or higher, then I'd be putting that patient on an insulin continuous infusion to decrease that glucose concentration to within the normal range, because hyperglycemia is associated with worse neurological outcome. So once we've dealt with airway, breathing, circulation, and neurological systems, we then go on to full body assessment in our patient. And really that just revolves around going back over the respiratory, cardiovascular, and neurological function and our abdominal scans to assess for the presence of bleeding and organ placement or displacement, evaluation of the skin or dermatological assessment, looking for bruising and discoloration, looking and evaluating at skin wounds on our patient, which in truth we might have already done already if they're really obvious, but this sort of secondary survey really helps us to identify all of the other injuries in our patient as well. And then we can also evaluate skeletal and neurological function. Now, I will say, just on neurological function, cats, when they're in shock, do not respond normally to neurological assessment. A cat that is in shock may have an appearance of loss of deep pain in all four limbs, a complete inability to stand and walk, abnormal mentation as well, loss of gag and swallow responses. When that patient has been treated for shock, frequently that patient's able to stand and walk, responds normally to your stimulation. So definitely repeated neurological assessments are vital when you are evaluating your patient. Now, I see a question there about when do we apply analgesics to our patients. Very early on. In fact, I like to do a neurological assessment very, very quickly in my patient. I'll assess them for the presence of shock, respiratory distress, and neurological function. That takes literally, even though I've taken 25 minutes to talk about it, we're going to be doing that in a period of about 5 minutes or so, by which time we are going to be able to, while we're getting our patient on fluids and everything else, we'll be able to give it analgesic therapy. And the analgesic therapy you're going to use in your patients begins with an opioid of your choice. My choice in cats is usually fentanyl. For significant dog bite injuries, it may be something not quite as strong for less severe injuries, but I really like fentanyl. You might choose to use methadone in your practice, and that's perfectly okay as well. Just watch methadone and fentanyl to a somewhat lesser degree with respect to respiratory function, because any opioid can cause a decrease in respiratory rate, and I have seen animals develop pinpoint non-responsive pupils, indicating an increase in intracranial pressure after they have been given an opioid for their analgesia. So just really reevaluate your patient after you've given them analgesics. There are a couple of other questions. Joe asked the question, any comments on the impact of the victim's body condition on the risk of complications after bite wound? Yes. So the extremes of body weight seem to carry increased risk. So those animals that are cachectic are not in the best position to be able to mount an adequate immune response to any infection that they may get. They are also not in the best place to be able to repair body tissues in the state of cachexia as well. They will lose more body heat. They are at a much higher risk of developing infections as a result of that. So, and certainly patients with decreased body condition or cachexia are much more likely to develop infections of the respiratory, GI, and urinary tract as well, simply because they are unable to clear those organisms, invading organisms through those tracts, and as well as a normal patient. Patients with high body fat content. Fat doesn't have an overabundance of blood supply. And so if fat gets crushed or damaged by a bite wound, it can act as a significant nidus for the development of an infection. It also gets damaged and can cause significant body inflammation long before our antibiotics have a chance to get there to kill infection, long before we can get this steatitis or inflammation of fatty tissue, and that can cause significant systemic inflammatory response syndrome as a result of the massive amount of inflammation that occurs due to damage of that excess body tissue. So the extremes of body weight, absolutely. All right, a full body assessment. Next, we're going to get to the bite wound itself. And the reason, this is oftentimes what our bite wounds look like, right? They've got matted hair and all that sort of stuff in them. We manage bite wounds in cats the same as we manage them in dogs. We need PPE, personal protective equipment, to ensure that we don't introduce something into this wound that is not intended. Okay, you want to fill this wound initially with a hydrogel, something like Solocite or Opsite gel, something of that nature that is a glycerine-based hydrogel. And then you want to cover that, if you can, with some sterile swabs. Then we're going to clip up this area as best as we can, usually with our patient with its analgesics on board, maybe even local anesthesia around the wound, or using a local nerve block, if at all possible. So we can then, or we're going to sedate our patient or lightly anesthetize our patient. But for our initial wound clearance, sometimes we'll just use maybe a splash block of local anesthesia around here so that the patient doesn't feel too much, or we'll use maybe a little bit of a ring block of local anesthetic. Now, cats are a little more sensitive to doses of local anesthesia than dogs are, but cats will tolerate up to around about 1 to 2 milligrams per kilo of lignocaine administered subcutaneously. I probably wouldn't go much higher than that. The toxic dose for lignocaine or lidocaine, depending on where you're from, is around about that sort of 4 to 6 milligram per kilo. So by using about 1 milligram per kilo, you're staying well within that acceptable dose range for therapy in your patients. Just always draw back before you inject, just to make sure that you're not injecting this intravenously as a bolus, to minimize the risk of cardiac complications and seizures in cats. But local anesthesia can be used reasonably safely in these patients. As I say, hydrogel in here, cover the wound with some sterile swabs, and then shave up this area as much as you can. Take off the swabs, flush the wound as much as you can, then put some more gel and swabs over the top, and then clean the skin around afterwards. So you're doing sort of like a double cleaning of this particular wound itself. And then you would want to try to flush this wound as much as you can with a sterile solution. Now, there are a number of sterile solutions. Most people would say, flush it with sterile saline, and sterile saline is okay. Is it the best solution? Well, there's lots of theories around whether or not it is the best. It's more acidifying than, say, a solution like lactated Ringer's solution or Ringer's acetate. And so in theory, it could potentially cause more damage to the underlying tissues. Clinically, I'm not sure that we appreciate much difference in wounds that have been flushed with saline as opposed to those flushed with lactated Ringer's solution. But if you are concerned about the viability or the amount of tissue that you have to close this wound, then I would probably be using lactated Ringer's solution or Ringer's acetate over something like 0.9% sodium chloride. That's my personal preference. It's backed up by theoretical literature. Practical literature, we simply don't have any any of it there. So there's no evidence to refute what I've just said. There's no evidence to support what I've just said, apart from the fact that in experimental studies that 0.9% sodium chloride is more toxic to cells than lactated ringer solution when it's left in contact with them for more than 10 minutes. So that's the reason why I prefer a balanced, less acidifying electrolyte solution over 0.9% sodium chloride. I've already talked a little bit about bite wound, the wound preparation itself. So gel in here to start with, cover it with sterile swabs, shave up as much as you can around it, then take everything off, fill the wound with gel again, put some sterile swabs in again, then clean the skin and then flush the wound. That's kind of the way that we would do this. Now, as far as surgical debridement is concerned on our patient, surgical debridement is really going to be determined, or the extent of surgical debridement is going to be determined by where the wound is, how much skin you have as well, and for closure, and how much damage there has been to subcutaneous tissues. So the ideal is that we remove all dead and necrotic tissue. We remove that tissue back to a bleeding surface so that we know we have good blood supply in our wound. And then we, again, flush the wound with sterile crystalloid solution, and then we either close the wound if there's enough skin there, or we do a staged debridement where we treat this animal with an open wound and then close the skin sometime later. When do we use chlorhexidine for wound cleaning? That's a great question, Chua. Thank you so much for asking that. So chlorhexidine is also a little bit cytotoxic, so I often don't use it in my initial wound flushing just as I'm preparing the skin, but preparing the wound. But you're certainly going to use chlorhexidine to clean the skin around the wound just prior to surgical debridement. And if you have contaminants that are deep in the wound, or if you have pre-existing wound infection, then chlorhexidine flush can be quite helpful for reducing bacterial numbers in an infected wound, especially if the wound is quite deep and difficult to fully clear out. So that's something that can be utilized as well. The strength of that solution is 0.05% when we're using dilute chlorhexidine for that lavage. For any lavage of wounds using either saline or lactated ringer solution or chlorhexidine is usually a 25 to 30 ml syringe and an 18 gauge needle. That's enough to give us 8 pounds per square inch pressure approximately. And the reason why we've chosen 8 pounds per square inch pressure using that 18 gauge needle, 25 to 30 ml syringe, is that that's the approximate pressure that bacteria find it very difficult to adhere to tissues. So it is actually able to dislodge microorganisms as well. What about iodine? I'm so glad you asked about iodine. Iodine, the only time we use iodine is around facial wounds where we're worried about chlorhex coming in contact with the eyes. So iodine for facial wounds or wounds around the eyes as well, apart from patients so the other thing that I will mention about iodine is that it is inactivated by organic material. So if you have a really dirty wound that is not around the face, then chlorhexidine is much better than iodine. So I don't use iodine in any wounds apart from those that are around the eyes or the face. What about peroxide? Peroxide is not something that we'd recommend. It's quite cytotoxic. It's great for killing bacteria, but it also kills too many normal cells. And so there's some concern about it impacting wound healing as well. How long after the wound are we considering debridement? How long do we wait to see how much tissue is going to die off? So there's two good questions in that question, Nikki. Thank you for asking that. So when are we going to do this surgical debridement? This is what we call a $64,000 question, right? I've had my patient, it's traumatized, I've stabilized it. When do I take it to surgery? The arguments go like this. If I take my patient to surgery too soon, it may not be hemodynamically stable enough and my anesthetic risk is increased. And my patient may die under anesthesia. That's one part of the coin. The other side is if I have damaged tissue or contaminated tissue, dirt and bacteria in a wound, the longer I leave that wound unattended, the worse my patient's inflammatory response is going to be, and the more likely my patient is to get systemic inflammatory response syndrome and sepsis. One of the key rules or tenets for treating sepsis is early source control. And what that means is that you remove the infected nidus at the earliest possible opportunity. So there's a fine line that you and I as veterinarians, and I know we've got some vet nurses and techs here as well tonight, so our whole veterinary team has to work together to make a decision about when to take this animal to surgery. And in all fairness, we don't have the right answer for every patient. However, it seems that patients, at least drawing on data from humans and some canine data as well, patients that have wounds that have not been surgically debrided for more than 12 hours are more likely to develop systemic inflammatory response syndrome and sepsis. So we really are thinking, I want to take my patient to surgery before 12 hours. And so somewhere in my hands, somewhere between 6 and 12 hours, I want that patient on a table doing surgery on it to decontaminate that wound so I can minimize the risk of my patient developing SIRS and sepsis. My patient might not be hemodynamically as stable as I would like, because it might take 6 to 24 hours before things like myocardial contusions and pulmonary contusions to reach some sort of stability. So my patient, yes, they're a little bit more unstable. But what are the consequences of me delaying surgery? Well, if I delay surgery so that my wounds get infected, then I'm more likely to have a hemodynamically unstable patient that's going into SIRS and sepsis. So that's why I say there's this fine line. So the first part of your question, how long after the wound are we debriding them? 6 to 12 hours is the kind of window I'd be aiming for. And I've seen literally hundreds of these patients, both dogs and cats, and that seems to be the time, at least in my hands, where we get the best outcome. Patients that I've seen that have not had surgery, and it's 15, 18 hours after the trauma, they oftentimes have got significant peripheral edema, they're hemodynamically unstable, they've got fluid leaking out in their lungs, they've got crackly lungs, or they've got B-lines or fluid sitting in their pulmonary parenchyma. It's not great. So there is this fine line. So hopefully that answers that part of the question. How long do we wait to see how much tissue is going to die off? So this is the second part of this question, where if I've got a patient that has a wound where I've got plenty of skin, plenty of soft tissue. So I'm thinking body wall on the dorsum or ventral abdomen and so on, where there's usually lots of skin, especially in cats. They've got this lovely elastic sort of subcutaneous layer of tissue. I will remove any tissue that is devitalized. I will remove as much fat as I possibly can that is involved, that looks bruised or discolored. Remove all the fat you possibly can from your wound. Debride all of your exposed fatty tissue to a nice clean plane. You need to be really aggressive with fat resection because, as I mentioned before, it's got a poor blood supply, and once infections get in the fatty tissue, they're really hard to manage without a second surgery. So really debride fat doesn't serve any purpose at all in your animal's wound. But when it comes to other soft tissues like muscles, we resect down to bleeding surfaces, then we kind of close what we can, and then do we manage them as an open wound really is determined by how much skin I have there and if I'm able to put an effective drain in place to drain the fluid which will inevitably accumulate in that wound as it's healing up. However, if I have a wound on a distal limb, so below the stifle, below the elbow, there might be limited soft tissue that I have available for reconstruction. So it's very seldom that I will, A, remove all tissue that is just a little bit on the line. I'll remove clearly devitalized tissue. But if tissue is just bruised and I'm not sure if it's going to be viable or not, leave it in the wound. It might be quite helpful for you, and you can always go back and debride that in a second surgery. Same with the skin in a lower limb. There's a limited amount of skin in the lower limb unless you're going to do skin grafts, which you might do down the track if you need to. But in the initial debridement, I'm not that aggressive with skin removal unless the section is completely devitalized. Let's say I have a piece of skin with a tag like this, okay? I might consider removing this distal part of the skin here because this segment that I'm looking at here is probably not going to survive. Okay, so I remove the sharp pointy bits so that I've got at least a bit of a base. I'm not get this little sharp pointy bit that I've just circled is not going to then contribute to my wound infection at all. So hopefully that answers the question. And Jose, you asked, do I close the wounds after surgical debridement or keep them open? It does depend very much on how much soft tissue there is afterwards. Lavage, I've already talked about lavage of the wound, so I won't re-go over that. My preference is to use lactated ringers or ringers acetate in wounds because it's buffered and it's less toxic than anything else. If I've got a clearly infected wound, then I might use 0.05 chlorhexidine as a flush as well after I have flushed with my lactated ringer solution. To closure, delayed or primary, these questions that you guys have asked are absolutely fantastic. It's meant that I've actually covered a lot of this as well. So imagine you've got this wound here. Okay, yes, we're going to clean this up. We are going to shave this up. I'm going to fill this wound here with a hydrogel, sterile hydrogel. Make sure it's a brand new tube that you're opening or a sachet of sterile hydrogel to cover all of this up while I shave it all up and see what's viable and what is not. Then we're going to put a sterile dressing on our patient's wounds. Now, most wounds, if you take one thing away from wound management lectures, it is the phrase warm and moist, because wounds like warm, moist environments to heal up. So that is the sort of environment I want beneath my patient's wound. Initially, because these wounds are contaminated, I'm going to avoid putting on an occlusive dressing, except, as I mentioned earlier, we're going to put on that vented occlusive dressing for open chest wounds just during our initial patient stabilization. But after that, once I've closed my patient's hole in the chest wall up, I'm then going to put a non-occlusive dressing on. Why? Because I don't want to trap bacteria in my wound itself. I want them to be able to get into my bandage, and so that when I take my bandage material off, I take a bunch of foreign material and bacteria away with that bandage, so they're no longer sitting in the animal's wound. So what are we going to use? My favorite bandage is Elevin, and Elevin is a foam bandage. It's non-adherent. I will fill up my wound with a hydrogel, so something like Solocite or Opsite gel in that wound itself, and then I'll put my Elevin on top of that, try to conform it as much as I can to the patient's wound, and then I'll just put a sterile cotton wool around the top of that dressing, then tighten that down a little bit with some conforming bandage there so it fits nice and snugly on the wound. And you might need to change that bandage every 12 hours if it's striking through in that period of time, or you might be able to wait for longer, up to 24 hours. But oftentimes in the first 12 to 24 hours, I think a 12-hourly bandage change is ideal for these wounds, because it enables you to clean out the wound, flush it out, see what's vital, what's devitalized, maybe perform a second debridement if necessary. The dressing name, Elevin is the dressing name there. Should we consider rabies vaccines for our patients? Where I live in Australia, we don't have rabies, so we don't do that. But I do know that rabies vaccines are given to a number of animals. I do know that usually they're given in the limb. Certainly there is some association, I think, with some of these vaccines, maybe an association with soft tissue sarcomas from earlier rabies vaccines, but I'm probably not the best person to consult with respect to rabies vaccines. So if you are in an area that has endemic rabies, just let us know if you routinely vaccinate your patients in the chat there. That'd be great. I'll learn something tonight as well. Antibiotic therapy. I'm guessing, if I was to do a poll right here, right now, that if I said, who's going to give your dog attack victim an antibiotic injection and a course of antibiotics, almost all of you will say yes. And I'd love for you to tell me in the chat there what antibiotics you're currently using in your patients, because here are the strict indications for antibiotic use. If you've got penetrating wounds that are contaminated, well, these are bite wounds. They're going to be contaminated if you've got skin damaged as well. Devitalized tissue is at risk of infection. So if you have patients in which there is questionable tissue viability and you're not able to remove it in our initial wound debridement, then these patients go on antibiotics. Systemic inflammation and sepsis require antibiotic use. So this really covers most of our patients that are bitten by dogs. We also use them in patients with multiple bite wounds, clinically infected bite wounds, sorry about the E missing on the bite wound, patients with a history of immune deficiency. Maybe they're on immune therapy for immune-mediated disease. Maybe they have diabetes mellitus, for example, or DKA. Patients with full-thickness wounds also need antibiotic use. So most of our cats that have been bitten by dogs will need antibiotic therapy. The sort of bacteria, it's interesting, most of these come from the skin and the oral cavity of the biter. The skin of the bitee and the oral cavity of the biter. So Staph intermedius and E. coli are the two most common bacteria that we find in isolates from infected bite wounds. Enterococcus and Pasteurella were the third and fourth place getters in who arrives in a wound there. I see lots of moxiclav, so amoxicillin clavulanic acid. There's clindamycin in there as well. And ampicillin and amoxiclav, that's also okay. And enrofloxacin, I see a vote for enrofloxacin in there as well. And what have we got? As a practice, not in a rabies-free country, I prefer to give the rabies vaccine shot, especially if the bite is from a stray animal. Nice. Thank you so much, Mohammed, for filling us in there. Clavulox and Baytril, so that's clavulanic acid, amoxicillin, and enrofloxacin. Awesome. There's a couple of votes for metronidazole in there as well. So this is really interesting because the recommendations in the literature are to have a beta-lactam plus a beta-lactamase inhibitor. So that is amoxicillin clavulanic acid. So Clavulox or whatever trade name you have for amoxicillin and beta-lactamase inhibitors, mostly because, you know, the Staph intermedius, big beta-lactamase producer. So you need to have something that covers for that. Plus or minus fluoroquinolones. Now, fluoroquinolones in dog bites to other dogs is controversial because you can actually end up with necrotizing fasciitis from the use of fluoroquinolones in dog attack victims in canine population. But the same thing doesn't necessarily occur in cats. So fluoroquinolones, they work kind of okay. They will kill gram-positive and gram-negative aerobic bacteria, but they're not all that effective against true anaerobic infections. So we had a question earlier that talked about a dog that, you know, if you're able to view the dog that bit the cat and it has severe periodontal disease, and there might be some bacteria like Fusobacterium and so on that might be living in that mouth, I would be inclined to be giving some sort of anaerobic coverage as well. So metronidazole may be a little bit better. as well. Now, Nikki's mentioned, would marbofloxacin be better than enrofloxacin? Maybe, okay, because certainly there is some concern about enrofloxacin in cats. So I think that would be perfectly fine. So the references that I consulted for this lecture just specified fluoroquinolone, and I think, and they were reasonably recent references, but they didn't necessarily specify the antibiotic that we would use. What would I use for a cat that had been bitten by a dog? I'd be using amoxicillin, clavulanic acid, and either metronidazole or marbofloxacin. Interestingly, the earlier you start antibiotics, potentially the better your patients will do, especially if they go on to develop sepsis. Okay, because we know that early antibiotic therapy in septic patients is associated with improved outcome. For every hour, if you're a human being in hospital and you get sepsis, for every hour that you get antibiotic therapy delayed, your mortality rate increases somewhere between 7 and 12%. Wow. Okay, we don't have data for that in cats, but I'm thinking I want antibiotics, if it were me, quite early on. So I'm going to give them early to my kitty cats as well. The prognosis in dog bite wounds in cats is dependent on a few things. The more areas of your cat that are injured, the worse their prognosis is. That kind of almost goes without saying. The higher the acute trauma triage scale is, the worse your patients will do. Injury severity, the more severe your injuries are, the worse your patients do. If you have low total protein or low albumin, that is associated with higher risk of complications, as is an increase in ALT. This is an interesting one. One of the papers was a review of a number of cats, about 67 cats, and it found that animals who had just needed conservative treatment of their wounds, that is not a highly aggressive surgery, entering a body cavity in particular, that they had a better outcome than patients who required invasive surgery. Now, these studies are retrospective studies that produce this data for us, and I think it very much depends on the surgeon, how long the surgery is, the clinical status of that patient, the time from the bite wound to surgery, as we talked about before. There's lots of things with respect to surgery that this paper was not able to filter out. So I'm not sure if some of these cats had surgery. Well, I do know that some of them had surgery at 18 and 20 hours after their bite wound, which is, in my book, probably placing them at a higher risk for non-survival anyway, because surgery's been delayed for a period of time. Interestingly, animals that had vertebral body fractures, not necessarily with associated neurological dysfunction, also had worse outcome. I do just want to finish off now talking about an introduction to feline sepsis. This feline sepsis in 3 slides. I promise no longer than 3 slides. How do I know if my dog attack cat victim is developing sepsis? Well, because cats are cats, they're kind of special. And in that case, they display highly informative symptoms. I'm being a little facetious here, and that is they're lethargic and they might go off their food a little bit. A lethargy and anorexia could be any sick cat. It could be a nearly dead cat with sepsis, or it could be a cat that's just got a cat bite abscess formed, and with a local infection. Some of these cats will have pyrexia. Some of them will have low body temperature. Some of them will have low blood pressure. And some of them will have abdominal pain, even if the abdomen is not involved in the pathophysiological disease process. So there may be nothing going on in the abdomen, but the cat may show abdominal pain. So the clinical appearance of a cat with sepsis is one of lethargic, anorexic, or hyporexic cat, maybe with an abnormal body temperature. You might be lucky enough to get hypotension or unexplained abdominal discomfort. So not terribly helpful. So that means you and I, in our dog bite cat patients, we need to have a high index of suspicion that this patient is developing sepsis. How do we treat sepsis in the cat? Well, that's a subject of an entirely different lecture. But in short, we need to resuscitate our patient in much the same way as we described today. Early antibiotics and early source control, which means for our dog attack victims that we are going to need to do surgical debridement on them as soon as we possibly can. And at the time, maybe get some samples for culture and sensitivity. Interestingly, there doesn't seem to be any benefit in getting culture and sensitivity samples shortly at your first surgery. You're actually better to wait until your wound gets infected and culture the bacteria that's left there. There doesn't seem to be any benefit in getting a culture and sensitivity from your initial wound debridement. So to wrap up tonight, and I apologize for going a little bit over time, just make sure we treat life-threatening injuries, treat the bite wound like we would treat any other wound in our patient, and keep a really close eye on development of SIRS and sepsis, and manage these patients as best you can with all of the equipment and gear that you have in your practice. As I mentioned, Chantel's just mentioned, actually in the Vet Education Library, we do have a review on feline sepsis, a lecture that I gave a couple of years ago, some good lecture notes and a whole bunch of journal reviews too on feline shock as well, that are also helpful to run hand in hand with this lecture as well. And we'll be talking about a lot of that stuff in our upcoming course on trauma. So that wraps up dog bite wounds in cats. I want to thank you so much for attending tonight or coming along, and for your great questions as well. This lecture has been brought to you by an upcoming course, Management of the Small Animal Trauma Patient. It starts on June the 10th, 2024. And because you've come along to this lecture, you get a discount if you sign up. So I will leave that slide on the screen there, and I'm so happy to take some more questions from you should you have them now as well. Do I use meloxicam, and if so, when? So the short answer is no, I don't use it. Certainly not any time at all. These guys for pain relief, usually on fentanyl, maybe ketamine, continuous infusions, depending on how they need it. On their level of discomfort, plus local anesthesia if that is helpful for my patients. Just note that if you're using local anesthesia in a limb, you've got to wrap that limb really, really well with a nice thick padded bandage, because cats will tend to want to chew at limbs when they're a little bit numb. So that is one thing to mention. When would I use meloxicam? Really only when the animal is on its way out the door to go home, if it needs ongoing analgesia at that point. And at that stage, I'm using a really low dose, might even be less than the minimum therapeutic dose there, to augment what I've already given my patient. I just felt that was such a good question, Cara, so thanks so much for asking that. And no problem at all in the late question. Really appreciate it. Please reach out if you have any questions at all. Please feel free to contact us at Vet Education anytime. Thank you for your lovely, kind comments there in the chat, and we hope to see you very, very soon. Thanks, everybody, and good night.